Come, sir.
Next is about the lymphoblastic leukemia. Now again, as in case of the myeloid leukemia, with the lymphatic system leukemia also, it's categorized into two categories as acute and the chronic. Now acute is defined as acute lymphoblastic leukemia is defined as a presence of lymphoblasts in the circulation, peripheral circulation. Under the microscope, a lymphoblast will be seen as a large cell with round or oval nucleus, and the chromatin tissue is clumped together, and the nucleoli would not be seen clearly, and cytoplasm would be very less there, and that kind of a cell, that's the precursor cell of the lymphocytes, that's what we call as a lymphoblast. And seeing these lymphoblasts in the periphery is the major sign of lymphoblastic leukemia. Now, the incidence of lymphoblastic leukemia, acute lymphoblastic leukemia, is maximum in Italy, United States, Switzerland, Costa Rica, etc. in the Western countries, and it's increasing every year by 1%. In India, it is the most common leukemia in children, accounting to 35% of all hematological malignancies in children. Adults, the prevalence of the acute lymphoblastic leukemia is around 7.3 to 57.8% in India. So comparatively, compared to Western countries, the incidence of acute lymphoblastic leukemia in adult is lesser. And the overall survival rate for children with the acute lymphoblastic leukemia in India is estimated to be 45% to 81%, whereas survival rate for the lymphoblastic leukemia has improved globally over the last 4 decades, with the 5-year survival rate of around 90%. In other developed countries, it's around 90%, whereas in India, it's around 45 to 81%. The malignant cells of the acute lymphoblastic leukemia are mainly lymphoid precursor cells, that lymphoblasts, and they are arrested in an early stage of development, and this arrest is caused by an abnormal expression of the genes. So the whole evolution is of lymphoblastic leukemia starts with some genetic abnormality, genetic expression would be modified, and this is now identified as the translocation of the chromosomes altered with the different chromosomal numbers. And as per the standard hypothetical evolution of the disease, the whole process of the changes in the genetic material, that chromosomal abnormality, it starts as a gradual process and it gradually progresses. So initially at one stage there will be only the chromosomal changes, but there will be no clinical evidences, or even when you see the blood picture, there may not be any abnormality in the initial stages. But as it accumulates, it results in the lymphoid precursor cells, the blast cells coming into the circulation, and they initially get accumulated in the bone marrow. And at that stage, the causes, of course, in that stage, the causes could be many, and because of the bone marrow getting expanded, the patient would have either the symptoms of either a bone pain, particularly the pain would be more acute rather than that of the myeloid leukemia, and particularly in children. And weight loss, fever, chills, night sweats would be the common symptom at that stage. Then as it progresses further, the number of blast cells in the periphery would be increased, in the bone marrow also they increase, and they also tend to go into the peripheral circulation. As they go into the peripheral circulation and the bone marrow functions are affected, at one stage there will be reduced to WBC count, pancytopenia would occur, and that would result in reduced number of neutrophils, reduced number of RBCs, reduced number of platelets, whereas the lymphocytes, lymphoblasts, they may be increased in number, and at that stage there will be, patient would be more susceptible for infection due to the reduced neutrophil count. Patient would have anemic features, fatigue, shortness, or even breathlessness also could occur. And due to the reduced platelet count, the patient tends to have petechia or tendency for bleeding. And when it becomes 20% of the marrow is having blast cells, then there would be it may be positive by biopsy. Till then, when you do the bone marrow biopsy, it may not show the evidences. Only when it becomes 20% more of blast cells, then by the chances of your bone marrow biopsy becoming positive is higher. Now, as the condition progresses, the blast cells, they fill in the bone marrow and they come into the circulation in large number. And as a result of that, the total number of blast cells in the periphery, they will increase in large numbers, and they also get accumulated in the lymph nodes in the periphery. And as they are blood in the periphery, also the blood cells would be, these blast cells would be identified in the periphery. And as a result of these deposition in the lymph nodes, there will be lymphadenopathy. The lymph nodes will be swollen, and usually the lymph nodes will be swollen in large, almost throughout the body, mainly in the cervical area, commonly in the cervical area. But characteristically, the multiple lymph nodes are involved. At the same time, there also would be splenomegaly as a clinical sign. As a result of the increase in the blast cells, the total leukocyte count may be increased. See, initially there would be leukocytopenia in the initial stages, then the leukocyte count may become increased. Further, as it progresses further, the bone marrow would be affected significantly, and hence there would be destruction of the cells in the bone marrow, and the total uric acid and other contents of the intracellular contents, they will be increased remarkably, resulting in hyperuricemia. The total uric acid level will be quite high, and this also can result in tumor lysis syndrome. We will come to that. Kidney injury could occur. Gout-like clinical presentation also could occur. There will be hyperkalemia, the potassium level will be raised, and LDH hormones also tend to be raised. That would be the total course of the disease of acute lymphoblastic leukemia. The common clinical symptoms which you can identify in the patient would be mainly that fever, usually a persistent fever for a long time, which becomes indolent or which doesn't respond to the usual conventional treatment. Anemia signs like pallor, fatigue, dizziness, palpitations, or hemic murmur, dyspnea with the mild exertion. These are all the typical clinical symptoms of the anemia, which also could be the presentation symptoms of lymphoblastic leukemia. Bleeding tendencies or disseminated intravascular coagulation may be in around 10%. Tendency to have the blood clots due to abnormality of the platelets functions, or lymphadenopathy. The most of the times the clinical suspicion starts when the patient would have a lymphadenopathy, lymph nodes becoming swollen. Until then, the symptoms would be vague, and naturally the differential diagnosis will be something more different, and most of the times you will have a different line of treatment. When the patient has a lymph node enlargement, that leads to the suspicion of the lymphoblastic leukemia. Then splenomegaly is another of the symptoms which can also result in the same issue. Then there could be even the lymph nodes again, they may be increased in the mediastinum, their number would be increased, and size also would be increased in the mediastinum, particularly in one variety, that's T lymphocyte leukemia conditions. And when the mediastinal mass is increased, patient may have more of pain in the mediastinum, shortness of breath, or even there could be swallowing difficulties. When bone pain, which can be severe, and there may not be any specificity, it could be atypical, like when it occurs and when it doesn't occur, that cannot be made out. Upper quadrant fullness due to the splenomegaly in around 10% of the cases. Leukocytosis or leukostasis is result in stasis of the WBC because of the increased WBC count. That there will be respiratory distress or even mental status could be altered. Kidney failure in patients with high tumor burden, let's say in the advanced stages, it can result in kidney failure. Infections, particularly pneumonia, petechia, or rashes, which are the common clinical symptoms. To make the diagnosis of a lymphoblastic leukemia, acute lymphoblastic leukemia, the NCCN guidelines say that there should be a demonstration of at least more than 20% bone marrow lymphoblasts. Either when you do the bone marrow lymphoblasts, there should be at least 20% of the lymphoblasts, and it has to be, the assessment has to be done by the GMs are right stain in bone marrow as great. Hematoxin and eosin stain bone marrow and close class sections in both GMs stain and HIV stain. The abnormal lymphoblast can be they should be identified. That is to prove that the nucleus material has the same character. Then then the next is about the evidence by immunophenotyping, that identification of the immunological factors. I will come to that, which are those base markers of immunological factors. They also have to be identified. And the leukemic clone, the identification of the leukemic clone, so which requires advanced methods of diagnosis for a confirmation of the diagnosis of acute lymphoblastic leukemia at early stage. But from our routine clinical point of view, we may not have the facility for these investigations, and bone marrow biopsy is never done as a first choice in our setup in our clinical conditions. So we usually depend upon the peripheral smear studies, and the peripheral smear studies showing lymphoblasts would always be an advanced stage. The other evidences, in addition to these, other evidences which could be seen in case of acute lymphoblastic leukemia could be radiological evidences of the bone marrow changes, and characteristically, one of the features, particularly in children, would be the metafacial bands. At the area of metafaces, there could be horizontal thin density bands seen, which could be very characteristic, or it also can result in pathological factors. Now, these are the evidences of the bone marrow changes in lymphoblastic leukemia, and a good number of patients also are diagnosed when they are presented with the bone pain, and when you do the X-ray, you will find these evidences. That also could be diagnosis of acute lymphoblastic leukemia. And as well as the cure rate and the cure of the lymphoblastic leukemia prognosis, from again I will be presenting this mainly from the Indian point of view. 20 to 30% of the adults with the lymphoblastic leukemia only are cured with the standard chemotherapy regimens. And the again the line of treatment which is usually suggested is in the either induction chemotherapy, which involves 4 drugs like vincristine, prednisolone, anthracycline, and cyclophosphamide and asparaginase, or a 5-drug regimen of vincristine, prednisolone, anthracycline, cyclophosphamide given with a course of 4 to 6 weeks. There could be a treatment of CNS prophylaxis, unlike that of acute myeloid leukemia. Acute lymphocytic leukemia, they tend to develop meningeal leukemia, and particularly when it recurs, and hence in such conditions CNS prophylaxis in terms of anti-epileptic drugs or drugs which may help in the reduction of the cerebral edema like the diuretics, they may be indicated. The ultimate choice is particularly in adults, the stem cell transplantation is considered to be one of the best option or most reliable option in the treatment as such. That's about the acute lymphoblastic leukemia. I have made it very brief. We will not go into much detail there with the acute lymphoblastic leukemia. Then there comes the chronic lymphocytic leukemia. The chronic lymphocytic leukemia is a disorder characterized by progressive proliferation of mature but functionally incompetent lymphocytes. The lymphocytes, they would have the same morphology as that of the normal. They are mature cells, unlike that of lymphoblasts, but they are functionally incompetent. And when you see the peripheral smear, it's typically seen as a small lymphocytes. The lymphocytes would have a diameter of 20 to 26 microns, whereas lymphocytic leukemia lymphocytes, they would have a diameter of 16 to 18 microns, much less smaller than the normal cells. And otherwise the characters, they may look like normal, but their number would be more. Some of these peripheral smear may show abnormal lymphocytes as what we are called as smudge cells which do not have a nucleus and they do not have any acidic stain as such. That's the typical feature. Typically, a lymphoblastic chronic lymphocytic leukemia would be its onset is insidious, and most of the times there would be no other symptom. Only when the peripheral blood smear is studied, the blood smear shows the abnormality, and this is around 25 to 50% of the patients. and they will be asymptomatic in the initial stages for a long time. When the blood smear is studied for some other reason, when you find this abnormal lymphocyte count, you may conclude that it could be the chronic lymphocytic leukemia, and then the steps are taken. The other symptoms which usually can occur are mainly recurrent infections. The patient tends to have repeated infections of different systems of the body, pneumonia or maybe the other systems. Enlarged lymph nodes, liver or spleen, this also could be the other symptoms. Other vague symptoms which also could be often presented would be loss of appetite or early satiety, abnormal breathing, that again is a sign of late stage sign, like where there would be abnormality of the clotting mechanisms. Fatigue, night sweats also could be the signs of lymphocytic leukemia. Biomarkers, there are many biomarkers which are often studied. Again, most of the times they are not really used in the regular practice, but the standard biomarkers for diagnosing lymphocytic leukemia are either LDT, that's lymphocyte doubling time, or serum beta microglobulin, serum thymine kinase or STK, lactic dehydrogenase LDH. Now the one which we usually limit with our clinical parameters would be the LDH. The other biomarkers, they are very advanced these investigations which require more sophisticated study. Then the other biomarkers which also could be again in the list, that standard list would be CD38 or ZAP70, which again requires the molecular study of the cells, or genetic markers are studying the genes. The chromosome aberrations or genetic marker could also be used, which are named as either del17p or TP53, etc. These mutations of the genes and their study is again very advanced method of study, which generally is not done in the routine clinical practice. Now, the advantages of this study, why these cell studies are done, is from the point of view of predicting the prognosis. If particularly in the genetic study, which can give you some more clinical guideline for the outcome of their treatment, as well as the prediction, selection of the drug assets. If the patients have unmutated chromosomes, the outcome would be better, favorable. Whereas those which have a deletion, 11q deletion or 17p deletion, or mutation of the chromosome, their results would be unfavorable. That's the prediction of the prognosis would be one of the important issues. Then, in addition to worse prognosis, patients with that chromosome deletion would have resistance to alkaloidic agents and purine analogs, which are the common prescription in case of the lymphocytic leukemia, and hence, particularly if they have huge lymphadenopathy, so selection of the drugs also will be based upon this. So, oncologists who start with the treatment lymphocytic leukemia, they would prefer to have these chromosomal studies, though it's very advanced and quite costly also. Still, they are a asset. Then there is a method. This also helps in predicting the rating or the staging of lymphocytic leukemia. There are different methods of grading this lymphocytic leukemia. Now, the grading is again, the right stage is the simplest, the oldest rather, where simply based upon the clinical presentation and the peripheral leukocyte count, you may make out these stages. Like if the patient has a lymphocytes, chronic lymphocyte, these numbers is increased, then it comes as a lymphocytic leukemia. If the patient has enlarged lymph nodes, then right stage 1, and enlarged spleen and liver are both, then the right stage 2. If the numbers of platelets are reduced, then it comes a right stage 4. Or there is another staging, like binary staging, which also is another clinical method of staging the conditions, which also helps in predictions, and it depends upon the area of lymph node involvement and considered as the head and neck or Walde's ringlet in the oral cavity, acting like groin or spleen. So, and stage A is when the hemoglobin is 10 gram or above, and platelet is 100 into 2 lakh, 10 lakhs above. And stage B is when hemoglobin level is same as stage, but the lymph nodes are involved, more than 3 areas of lymph nodes are involved. Stage C is hemoglobin is less than 10 gram per dl and platelets less than 10 per 9 assay. Then there is that's about the clinical stage. International prognostic index is another of the method which is often used. Now all these staging methods are followed by oncologists to predict the outcome as well as to select the right course of the treatment, and that is calculated. There is a complex calculation method based upon age, clinical stage or binet, and serum immunoglobulin level, and mutation status of the immunoglobulin, and deletion or the mutation of the chromosome. And this again, which is again a very complicated issue, there is a website which gives you the total staging. The international prognostic index is calculated on its own, and this is a URL. So of course, most of these are not useful in routine clinical practice. This is mainly from the theory point of view. Now, the treatment protocol, the standard guideline of the treatment will be in the initial stages, patients with the chronic lymphocytic leukemia with low binet or high stage, that's where there is not much of a significant issue, and they are asymptomatic, they should not be given any chemotherapy. Chemotherapy treatment is not indicated. This is the standard guideline, and there are a lot of these articles which give you the statistical evidence of the benefit of avoiding any rigorous treatment at that stage where the patient would not have any symptom, but only it's identified with the blood picture and the stages. There are not much of lymph node involvement, and the bilateral right stage is lower. And many patients, they can be pulled on with just periodic follow-up for years together, many years, without having developing progressing into the next stage. If the patients have a low stage lymphocytic leukemia, they also are suggested to have only periodic follow-up, and this is seen that the initiation of chemotherapy in such cases has failed to show the benefit, rather it may increase the mortality. So this is a very important fact, and from one clinical point of view, this also is an issue. A good number of patients now come at that stage, and they would have questions like whether they should go for chemotherapy or not. I still suggest such patients not to go for chemotherapy at that stage, and usually what I prescribe would be Kumariyasava and Arogyavardhini to such patients. Now whether this Arogyavardhini and Kumariyasava really benefits such patients are not still questionable, but there are many patients who are maintained with that for years together. Only thing which we do is a regular follow-up of the patients. Now treatment is indicated when there is absolute need for the chemotherapy would be in patients with chronic lymphocytic leukemia, when it progresses into a symptomatic disease, and the guidelines define symptomatic or active disease, which comprise of that when to start with the treatment. The guideline, international guidelines would be weight loss at least 10% over 6 months, extreme fatigue, that's a performance status of 2 or more, that's a performance status, normal performance status is graded as a 4. So when the clinical activity comes to, or rather physical activity comes to half of the regular normal activity, that's the sign of extreme fatigue. Fever of at least 38 degrees for 2 or more weeks, and there is no evidence of infection. Night sweats for at least 1 month with no evidence of infection. Progressive marrow failure, autoimmune anemia or thrombocytopenia not respond to glucocorticoids. Progressive symptomatic splenomegaly or massive splenomegaly at least 6 centimeters below the costal margin. Symptomatic or massive lymphadenopathy. Progressive lymphocytosis as defined by an increase of more than 50% in 2 months. Symptomatic extranodal involvement including the spine. These are the specific indications. So start with the specific therapy, the anti-cancer therapy or anti-leukemic therapy. Otherwise, there is no need for treatment at that condition. This is the international guideline. But what happens is most of the times there would be a early treatment started, which is not necessary. The other indications for starting treatment is patients who have a tumor lysis and high burden disease, and treatment differs based on the age and cytogenetics. Consider allogenic stem cell transplantation for curative intent if patients have a good response to initial therapy. Once the treatment is started, if the patient has shown good response, then the bone marrow transplantation or stem cell transplantation is also recommended as a treatment once a patient recovers. And relapse of the disease that occurs more than 3 years later, retreat as the first line treatment. But if it occurs within less than 2 years, then second line therapies are suggested. And radiation therapy also is indicated in the early stages of lymphocytic leukemia. The drugs which are selected, again from our routine clinical point of view, these are not important, but the drugs, they are quite costly, and they are mainly the modulators, immunomodulator drugs. Either it could be Diviclam or Zemepinib acid and so on. So I think we will not waste much time on these issues. These are the selected drugs which are used in the chemotherapy. Response to the treatment is assessed by complete response is defined as all lymph nodes are smaller than 1 centimeter, liver and spleen become normal in size, no constitutional symptoms, leukocyte counts more than 1500 per cubic millimeter, and normal circulating lymphocytes, platelet counts more than 1 lakh, and hemoglobin level of more than 11 grams, and normal cellular bone marrow with less than 30% of the lymphocytes and no B lymphoid nodules. That's the sign that the patient has completely recovered from the lymphocytic leukemia. Stable disease is now certain of the patients, they are also categorized as a stable disease, where the therapy has benefited, but the disease is not completely cured. In such conditions, the lymph nodes are somewhere reduced by number by around 49 to minus 49 to 49 plus 49%. That's a lymph nodes compared to the before the start of the treatment, they are reduced as it. And liver and spleen size changes from 49 to 49, again minus 49 to plus 49%. That means either they are reduced and or slightly increased as it. Constitutional symptoms are absent. Leukocyte count is anything like abnormal, slightly abnormal but not very high. Circulating B lymphocyte count change again from minus 49 to plus 49. Platelet counts change from minus 49 to plus 49 compared to the baseline of treatment. Hemoglobin level is increased by 11 to 50% of the baseline, or decreased by 2 grams, and no change in the bone marrow infiltrate. Then we say that the disease is stable, is not progressing much. One of the complications which occur with the lymphocytic leukemia is a sudden aggravation of the condition, which is called as Richter transformation. It's a rare complication, and it results in a sudden aggressive type of lymphoma. And in such conditions, it's rare of course, but such conditions it becomes a emergency and the patient would have to be treated. With this, I will make it very brief as it. Now, these words of lymphocytic leukemia, myeloid leukemia, they are producing confusion. So there is a summary of mainly the 4 types of leukemias. Because the present classification is of very elaborate matters and producing more confusion, I think I would like to summarize the simple issues which you have to remember about the different types of leukemia. Acute lymphocytic leukemia, the clinical picture, the blood picture would show the lymphoblastic leukemias, lymphoblasts in large number. Causes are chromosomal aberrations which are seen. Typical cells involved are immature B cells or T cells in the bone marrow as well as in the peripheral smear. Their morphology is their condensed chromatin and scant cytoplasm, and nucleus is comparatively a smaller or average size. Clinical presentation is a sudden onset or rather onset would be somewhat rapid. Symptoms are related to the depressed bone marrow function like anemia or the other issues, and bone pain is the other symptom. CNS manifestations can occur occasionally, and the peripheral blood picture shows anemia, thrombocytopenia or variable WBC counts, and majority of them are lymphoblasts. More frequently, acute lymphocytic leukemia is seen, acute lymphoblastic leukemia is seen in children. Then chronic lymphocytic leukemia, there is a chromosomal deletion. If you study the chromosomal deletion, the peripheral smear would be showing the smaller cells, smudge cells, and condensed chromatin in these areas. Majority of the patients may remain asymptomatic or non-specific. Hepatosplenomegaly, lymph node enlargement, lymphadenopathy would be the other main clinical symptoms. The peripheral smear studies show sustained increased lymphocytosis and low platelet count, and most common leukemia in adults. In adults, this is common, and twice common in men. Then myeloid leukemia, acute myeloid leukemia, typically is presented with the R nodes in the cells as which we have discussed, and myeloblasts also are seen, and it probably is again due to the mutations of the genes as such, again which we have discussed as such. The cells involved are immature myeloid cells, and clinical presentation is mainly anemia, neutropenia, thrombocytopenia, and the myeloblasts are seen in the periphery with R nodes, and most common in adults. Then chronic myeloid leukemia is presented with the hypercellular marrow and elevated eosinophils and basophils in the periphery. It's usually due to the abnormality of the tyrosine kinase pathway due to chromosomal translocation. Philadelphia chromosome also is one of the known causes or known coexisting conditions. The other cells involved are pluripotent cells of the bone marrow. The onset is insidious. Mild anemic symptoms, splenomegaly are the major clinical signs. The peripheral blood picture will show very high WBC count of more than 2 lakhs or more than that, 10 lakhs or such. Blast forms may be seen, and eosinophils and basophils are raised. Usually more frequent in age of 20 to 50, rare in children. That's the summary of leukemia. So instead of going to all that complicated issue, I think that summary will be enough. With this, we will conclude about leukemia. The next session will discuss about lymphomas, particularly. Again, you have a detailed this classification. So I will try to make it simplified by limiting ourselves to Hodgkin's and non-Hodgkin's lymphoma. That will be in the next session. We will conclude today a bit early, but